We know that there are a few issues with medicines in care homes. Patients often get prescribed excessive medicines, quite often inappropriate, sometimes unnecessary medicines. There's often lack of detailed review, and patients don't really get a say in the decisions made about medicines. The Shine 2012 project aimed to address some of these issues. Our objective was to optimise medicines in older care home residents whilst fully ensuring that they were involved in all decisions made about them. We reviewed 422 residents, made over 1,300 interventions, and over the course of the year, through various measures, have shown that we really did improve quality of care for those residents. Our biggest intervention was to stop medicines. We stopped over 700 medicines in 2/3 of patients. The average number of medicines taken by these residents was 11, and we reduced that down to 9. This project was all about improving quality for patients, but by doing it we also showed that we released significant savings against the medicines budget, saving over £80,000 in a year. We know that by investing £1 in this project you can save over £2 from medicines. There were other efficiencies too. We showed a reduction in drug waste, so that's medicines going back to pharmacies to be destroyed. We also showed a significant reduction in the amount of time nurses spent giving medicines to patients, which is fantastic, which meant that they can now use that time to care for their patients. One of the biggest pieces of learning I personally got from this project was getting the team right, making sure that you involve the right people, get advice from the right people, and listen to that advice. We were lucky to have GPs, care homes, consultants, and a whole range of other stakeholders supporting us. For example, Age UK helping us with patient advocacy. My proudest achievement for this project has been that we've given care home residents a voice and a say in the medicines that we take.
My involvement in the Shine project was first to give advice to the team about setting up the project. That's partly because my team works in the care homes and this project was in care homes, so we had some of the knowledge about how to approach people in care homes and so forth. But the second particular thing was that we were able to focus on issues around capacity and consent and talk to the researchers about how they should set about checking that people were able to give consent and did have capacity. We should absolutely always assume that the person has capacity. It's one of the first principles of the Mental Capacity Act, and it's fundamental. The information we provide is absolutely crucial. I think that often this is overlooked or not emphasised enough because sometimes I think people presume that people already have the information, and then secondly, the amount of information that we give may well determine, and the type of information we give may well determine how easy or difficult it is for the person to pass the test of whether or not they've got capacity. You can help people to make difficult decisions in a variety of ways. One obvious way is just to make sure that the person understands the sorts of things that you're talking to them about. So if you're giving them information, you need to give them information in ways which they can manage. So for instance, this might crop up if you were dealing with people with learning disabilities. For instance, they might not be able to read, you might have to use pictures and so on. In some of the people that we look after, they might have quite difficult speech problems. And of course, one way to fail the test of capacity is if you can't communicate. But you should try and help the person to communicate. They may be able to communicate in other ways apart from just normal speech.
The medication review involves utilising all available resources, whether that be notes or healthcare professionals, to gain a good background of why a resident has been prescribed a particular medication. It allows you to make decisions about a particular medication, whether that be continuing it at a certain time, discontinuing it, or changing any particular doses. It's important to have the patient involved in the medication review because at the end of the day it's their medication that you're discussing. And also it might be that you're proposing stopping a medication and that's going to make them more anxious if they don't want to stop it, or if they don't know that something has been stopped or the reasons behind it. or it might be that you're contemplating starting a medication, but they actually don't want the medication. So I think because it's their medication that you're having an involvement with, they should be involved.
Shared decision making is a collaborative process where a healthcare professional will support a patient in making decisions about treatment options. So within shared decision making, the healthcare professionals bringing the evidence, potentially the outcomes to be expected, and as well as that maybe some negative effects that patient could experience and how likely it is that they could experience those. The patient will be bringing their values and their priorities into that decision making, so together they make a better decision that's more suited to the patient. In the care home project, the shared decision making aspect was in deciding, following the multidisciplinary team review, what patients' preferences were for any decisions on their medicines. The benefits of shared decision making is it's very important that we give patients a voice on decisions on medicines that they're taking. In care homes in particular, this is an environment where residents get little say in their medicines and little say in the decisions about their treatment. And as well, patients aren't responsible for the administration of medicines, so it's quite often that they don't actually know which tablets they're taking. When we actually broke down the decision and explained to the resident that we weren't expecting them to take responsibility for the evidence or the clinical expertise, but we really was trying to get their wishes, actually they were able to contribute to even complex decisions about medicines.
We met and looked at their medical records at the GP surgery, looked at which medications they were taking, when they were started and for what reasons. And then we met at the residential home with the senior carer and the patient, if possible, and if that wasn't practical, then with one of their relatives. And we went through each medication in turn, really deciding together whether it was in their best interest to continue to take it. It's benefited me hugely as a GP by optimising the patient's medications, which in effect for the majority of patients has mean that they're actually now taking less medications, and that means that their medication reviews are much more straightforward and simpler. I've also been able to foster a good relationship with the community pharmacist for future working together. And it's also given a great sense of pride in doing, in my work, and that we're doing the best we can for our patients. I feel the project has helped benefit the patients by reducing the burden of taking too many medications, because most people we've been able to reduce their medication. That means that they're less likely to get side effects that we might not otherwise have known about. They're less likely to have interactions with other medications. And hopefully it's also improved compliance in that they take the tablets that they really need and are more likely to take them.
Initially, when the home was being commissioned, nurses had very little time to understand the medication that was being given. The medication rounds were taken in a very long time. So the benefits have been around nurse education, understanding the medications, half the amount of medications being dispensed, so medication rounds massively reduced. Certainly a lot of involvement with the residents themselves and the families, being able to both understand the conditions that the residents have and the medications given. And families feel far more involved now in decision making, either with their loved one or on behalf of their loved one. They've got more insight into their conditions, more say and on what type of medication that their loved ones are actually given. It's been a huge benefit. I certainly feel safer as a manager. The nurses feel safer as nurses. The families are happier. They know exactly what's going on, particularly around end-of-life medication. Actually, that's been a huge benefit to be involved in those decisions. We've benefited hugely because of our improved communications and face-to-face meetings with our GP and pharmacy colleagues. So we've benefited hugely from that. More trust between nurses and doctors, managers and doctors, certainly.
I think the The reason this project has been quite unique is that our pharmacists have been able to use their prescribing skills and also develop their consultation skills, and particularly really emphasise the role of shared decision making when they're dealing with patients and their families. So we've really seen them develop as exemplars of good practice. The benefits from this project has been immense, really. For them as individuals, I think they've been able to transfer skills to other settings. But I think in terms of the benefit of the project, it's been a real benefit to the Trust, because it's really raised the profile of pharmacists being involved in shared decision making. And I think it's also highlighted the importance of involving patients and their families in decisions about the therapeutic use of medicines.